Hi friends, now we are going to discuss 10 important topics in the form of 10 questions. First topic is schizophrenia. Every time you will find one question, and when we talk about clinical questions, they give little bit different language. So let me describe first the criteria of schizophrenia. Yes, if we talk about DSM, in DSM-5, if you want to make the diagnosis of schizophrenia, the patient must have delusion. If we talk about delusion, yes, you will find in question that patient would say that he is suspicious of family member. Patient says that my family member wants to kill me, my neighbor wants to kill me. Delusion of persecution. Yes, somebody is talking about me. Delusion of reference. Sometimes a patient would say, yes, somebody has inserted chip in my mind, yes, and controlling me. Delusion of control. So different types of delusion may be there, and the word would be suspiciousness, and these symptoms would be there. So first point is delusion. The patient may have delusion in schizophrenia. Hallucination. The patient would hear a voice when there is no one around. Sometimes you will find the word self muttering, means patient is talking to self, that is hallucination. Third is disorganized thought, affect and behavior. Yes, disorganized thought, if we talk about disorganized thought, that is formal thought disorder. Frequently asked question. Commonly asked formal thought disorders are incoherence. In schizophrenia, yes, I am telling you the diagnosis of these questions would be schizophrenia, but how the language would be in question, long clinical questions. Just like the patient says that my Ankur, Delhi, India, okay, bye. This sentence would be there. This suggests incoherence. This is incoherence, or also called word salad. Yes, my Ankur, okay, Delhi, bye, means that is complete disorganization of thought. You can't make any meaning out of it. That is formal thought disorder. Second formal thought disorder, which usually you found in clinical question, yes, neologism. The patient would say that this is omni micro. This pen is omni micro. When patient is asked why he said this pen as omni micro, he would not be able to explain how he coined the word. So you will find these types of language in the question. So again, neologism is also formal thought disorder. It is most characteristic formal thought disorder question is asked. Perseveration. In perseveration, yes, if we ask question to a patient, what is your name? Patient would say, my name is Mahesh. Yes, where do you live? My name is Mahesh. What is your father's name? My name is Mahesh. Means continuation of same thought. Yes, that is Mahesh, Mahesh, Mahesh. So that is perseveration. Again, formal thought disorder. This is controversial. Perseveration and thought block, they are also considered as disorder of stream of thought. But in clinical question, you will find that perseveration is disorder of form of thought, and it is seen in schizophrenia. In the same way, thought block is also formal thought disorder seen in schizophrenia. What would be the language? In question, you will find that patient is speaking, suddenly stops and don't complete the sentence. Patient stops and don't complete the sentence. That is thought block. Means patient would not give any explanation. When you ask why aren't you speaking, the patient would not reply. That is thought block. So you will find these types of statement in clinical question, that patient is suspicious, patient is hearing voices, yes, formal thought disorder in the form of incoherence, neologism, perseveration, thought block. Okay, this is disorganized thought. Sometimes you will find flat affect, means there is no emotional fluctuation in the patient. Affective flattening seen in schizophrenia. Incongruent affect seen in schizophrenia. Inappropriate affect seen in schizophrenia. Abnormal behavior means picking things from the street, putting all these things, mud in mouth, means abnormal behavior, aggressive behavior. So 1 point delusion, second hallucination, third disorganized thought, fourth is catatonic behavior. Yes, I am taking time. The purpose is that you will find one question from schizophrenia itself. Recently, there is change in the classification in ICD-11 and DSM-5. Both they have considered catatonia as a separate diagnosis. Previously, we used to say that catatonia is a type of schizophrenia, catatonic schizophrenia. But now we say that catatonia is a separate diagnosis which can be present in many psychiatric situations. And the question was asked that most common cause of catatonia is. The answer was depression, not schizophrenia. So what are the symptoms or motor symptoms on the basis of which we can make the diagnosis of catatonia? First is stupor. Yes, patient, you go to ward and you saw the patient is not speaking to anybody. Yes, he is mute. He is mute. He is not speaking to anybody. He is not responding to your commands. That is stupor. Means not responding to command, no movement, not speaking. Negativity. Many times in clinical question you will find negativism. What is negativism? Means patient is not following your command and sometimes do opposite, negativism. And this is favorite question and controversial points are there. Posturing, catalepsy and waxy flexibility. Suppose you are given this picture and you are asked, yes, this may be posturing, this may be catalepsy, this may be waxy flexibility depending on the description, the question. Suppose you entered the ward and you found the patient in this posture. Means patient acquired this posture spontaneously. You will say the answer is posturing. You entered the ward and you are doing passive movement on the patient and you are feeling no resistance. Means passive movement, no resistance, and after doing this, you left this hand and patient maintained the same posture. No resistance, patient maintained the same posture. The answer is catalepsy. You are doing passive movement. You felt resistance just like you are bending a wax candle and you left the patient and patient maintained the same posture, means same posture. Now the diagnosis would be waxy flexibility. Same picture, three phenomena can be there. One is spontaneous, that is posturing. If no resistance and patient maintain the last posture, yes, that is catalepsy. If you feel resistance just like wax candle bending and patient maintain the same posture, that is waxy flexibility. Grimacing, many times the catatonic patient is sitting in the ward and he is maintaining abnormal facial expression, that is grimacing. Echolalia, yes, you ask something, what is the name? Patient would reply, what is your name? What is your father's name? What is your father's name? That is echolalia, echo of language. Lalia means language. Echopraxia, echo of movement, echo of movement. Whatever you are doing, suppose you do like this, the patient would repeat the same thing. Echopraxia, praxia means motor movement. So these are symptoms of catatonia. Yes, if out of these three symptoms are present, then we say catatonia. And as I told you, it may be present in depression, it may be present in schizophrenia, it may be present in medical condition. A question was asked, medical condition. Yes, hepatic encephalopathy may present with catatonia. Now, so I described all these phenomena and you will find separate question on these phenomena. But now we come to the diagnosis of schizophrenia. If we talk about schizophrenia, yes, four symptoms I have described. The fifth symptom, negative symptom, you all know, means patient is not talking to anybody, means decreased language, okay, alogia, decreased social interaction, asociality, decreased concern, apathy, decreased interest, anhedonia, no motivation, amotivation. These are negative symptoms. So according to DSM-5, if out of these five, two symptoms or more than two symptoms are present for more than 6 months, then you will make the diagnosis of schizophrenia. If out of these five, two or more than two symptoms are present, diagnosis is schizophrenia. If these symptoms are present less than 1 month, then you will say the diagnosis is brief psychotic disorder. Let me write here, brief psychotic disorder. So many times you will find question, the duration less than 1 month, brief psychotic disorder. More than 6 months, schizophrenia. If 1 to 6 month, 1 to 6 months, then the diagnosis would be schizophreniform, schizophreniform disorder. All are question, means the symptoms would remain same and the duration will decide that the diagnosis is brief psychotic disorder or schizophreniform disorder, or that is schizophrenia more than 6 months. So we have covered many important points about schizophrenia. Now we come to first question. A 25-year-old male developed auditory hallucination. Yes, hallucination is present. And disorganized speech. Yes, disorganized speech, you can say that thoughts are expressed in the form of speech. So disorganized thought for past 8 months. So duration is more than 6 months. Hallucination is there, disorganized speech is there. So diagnosis is schizophrenia, but they ask about the subtype. In ICD-10 they have given subtype, even now questions are being asked. So these patients also have mirror gazing, giggling, and the age is 25. So diagnosed subtype is hebephrenic schizophrenia. How to remember? Yes, paranoid, P4 paranoid, P4 positive symptoms, P4 positive symptoms. In paranoid schizophrenia, there is mainly positive symptoms. This include delusion and hallucination. In hebephrenic schizophrenia, there are disorganized symptoms, disorganized. Yes, it may be disorganized affect, disorganized thought. I have told you formal thought disorder. Yes, just like disorganized speech. So in this disorganized speech is there. So definitely answer would become hebephrenic schizophrenia, and it is also called disorganized schizophrenia. Now, if catatonic symptoms are there, then it is catatonic schizophrenia. If only and only negative symptoms, only negative symptoms are there, yes, in simple schizophrenia, you will never find positive symptoms in last 1 year. In last 1 year, this is very, very important according to ICD-10. Yes, if you want to make the diagnosis of simple schizophrenia, the duration of symptoms should be 1 year and only negative symptoms. Yes, you will find in few questions. Out of these, simple schizophrenia, worst prognosis, catatonic schizophrenia, best prognosis, and a treatment of catatonic schizophrenia. This is very important. Recently, INI-CET asked the question, yes, initial treatment. If we talk about initial treatment, the answer would be, yes, initial treatment, injection lorazepam, injection lorazepam. But if they ask treatment of choice, then answer would be modified ECT. Modified ECT, as you know, direct ECT is totally banned, and modified ECT we give general anesthesia and muscle relaxant. So treatment of choice for catatonic schizophrenia is modified ECT, and initial treatment we try injection lorazepam. It may be IM, it may be IV. Now, second question, again before going to question, yes, you have an idea. Yes, depressive disorder, if you want to make the diagnosis of depression, out of these symptoms, these are 9 symptoms, I am not elaborating, just giving an idea: mood, interest, decrease energy, low mood, decrease interest, decrease energy, decrease sleep, decrease appetite, decrease concentration, decrease psychomotor activity, guilt, worthlessness, and suicidal thought. Out of these, if 5 symptoms are there, how many symptoms? 5 symptoms. And out of these 5, 1 symptom should be from these 2. 5 symptoms are there for 14 days. Then you make the diagnosis of major depressive disorder, or you can say depression, major depressive disorder. So if a patient comes to you with these symptoms, and yes, I am giving you these ideas because you will solve multiple questions from this concept. Okay, 5 symptoms, 14 days, major depressive disorder. If these symptoms continue for 2 years, then you will make the diagnosis of chronic major depression. You will make the diagnosis of chronic major depression. Now, Suppose this patient comes to you at this point and he is having 5 symptoms out of these, yes, and you make the diagnosis of depression. You took past history. In past history, you found that there is a episode of depression, then you will make the diagnosis of recurrent depressive disorder. Yes, recurrent depressive disorder, yes. The same patient means you will find the same history in the question. Yes, I am giving you how questions are changed. Yes, out of these symptoms, 5 symptoms are there. For 14 days, the diagnosis is major depressive disorder. For 2 years, chronic major depression. Yes, you took history. Yes, past history, there is depression. You made the diagnosis of recurrent depressive disorder. If you took past history and you found that in past history there is mania, you will make the diagnosis of, yes, bipolar affective disorder type 1, BPAD. Yes, bipolar, both happy pole and sad pole are touched. Mania is there, depression is there, means bipolar affective disorder. And which type? Type 1. What is the purpose to tell you? Suppose this patient came to you having recurrent depressive disorder, same symptoms are there, out of these 5 symptoms are there. This patient comes to you, is in depression. What is the treatment? You will give antidepressant. You will give antidepressant. But this patient came to you having symptoms of depression, you made the diagnosis of depression, or you can say BPAD mania, current episode depression. Current episode is depression. In this patient, you will never give antidepressant alone. Never give antidepressant alone. Always give with mood stabilizer. Always give with mood stabilizer. So there are 3-4 questions in which they told that patient is bipolar disorder, now patient is in depression, you gave treatment antidepressant. Patient came with symptoms of mania, hyperactivity, overactivity, over-talkativeness, delusion of grandiosity. These symptoms patient came with this, means patient has switched to mania because you gave only antidepressant in bipolar depression. So that's why we say in bipolar depression, never give antidepressant alone. Yes, if you gave, so what will be your management? You will stop antidepressant and will start mood stabilizer. Got the point? Now, so you know about recurrent depressive disorder, BPAD1. Suppose the same patient at this time, patient is depressed and past history of hypomania, then you will make the diagnosis of BPAD2. BPAD2. In BPAD2, there is hypomania and depression. Now, we solve question. A 21-year-old woman returned home from college for her summer break. She appears sad. Sadness is there. Does not show any interest. Decreased interest is there. 2 criteria. Yes, interest in activities with her family which she used to enjoy. This is in fact anhedonia. Anhedonia means not getting pleasure in previously pleasurable activity. Yes, so she is having sadness of mood, anhedonia, difficulty in concentration, decreased appetite, decreased sleep, decreased energy. Yes, criteria of depression are fulfilled. But in this question, there is a stressor, recent stressor, that is breakup for 3 weeks. The duration is more than 2 weeks. Even if the stressor is there, you will not make the diagnosis of adjustment disorder. In this, the criteria of depression is fulfilled. Depression criteria fulfilled. Stressor is present. You will make the diagnosis of, yes, major depressive disorder. Got the point? But in the same question, let me tell you, yes, so this question answer is major depressive disorder. In the same question, yes, if you find that these symptoms are, yes, I have already discussed, these symptoms are for 2 years rather than 3 weeks. These symptoms are 2 years. The answer would become chronic major depression. So how they will change the point, one point, and the answer would be changed. In the same question, they gave history. Yes, they gave there is history of depression in past. There is history of depression in past. So this will become, the diagnosis will become recurrent depressive disorder. History of depression in past. In the same question, if they gave history of mania in past, means they will not give you that the history of mania is there. They will give like this: the patient, yes, 3 year back patient was treated for overactivity, for over talkativeness, delusion of grandiosity, and hypersexuality, increased sexual desire, decreased need of sleep. These symptoms were treated and patient was hospitalized. Means this suggests that patient was having episode of mania in the past. Means they gave the same question and they extended the question, long question, clinical question, and in they gave history of mania in the past. Now history of mania in the past, and now current episode is depression. The diagnosis would become bipolar affective disorder type 1. In the same question, if they gave history over talkativeness, hypersexuality, hyperactivity is there, but there was no admission, there was no socio-occupational dysfunction, means they were giving history of hypomania. Suppose they gave history of hypomania, let me take different color. Yes, if history of hypomania, in the same question, history of hypomania 2 year back, 3 year back, yes, the diagnosis would become BPAD 2. So the purpose to merge all these things is that long clinical question would be there, only 1 or 2 points will change the answer. In this question, the answer was major depressive disorder because 14 days criteria fulfilled, but if these symptoms continued for 2 years, the answer would be chronic major depression. If past history of depression, answer would become recurrent depressive disorder. Past history of mania, yes, BPAD 1. Past history of hypomania, BPAD 2. Now I extend, yes, I extend the discussion, yes, how these E, F or G option can be the answer in the same question. How these two can be answered in the same question. Same question, if I say energy is normal. Yes, in the same question, 21-year-old woman returns home from this disease and she is having sadness of mood. Yes, in anhedonia, decreased concentration, but sleep, appetite, energy is normal. Means diagnostic criteria of depression is not fulfilled. Diagnostic criteria of depression not fulfilled. And there is a stressor. Means stressor is there and diagnostic criteria of depression is not fulfilled, then the diagnosis would be adjustment disorder. Yes, if precipitating factor, stressor, that is subjective stressor, just like divorce, just like medical illness, just like financial loss, just like breakup from boyfriend. Yes, if these stressors are there, after that depressive symptoms starts. Yeah, definitely anybody would have these types of symptoms, but the criteria of depression is not fulfilled, then you will mark diagnosis at adjustment disorder with depressed mode. Clear? So in this question, yes, by changing this only one word, the answer would become adjustment disorder with depressed mode. Yes, question number 3. A 22-year-old woman is brought to OPD by her mother because of a 5-month history of feeling sad. Sadness is there. Yes, sadness is there. Mother says that during this period she has slept, eaten very little, decreased sleep, decreased appetite, unable to focus, decreased concentration. Yes, she feel tired, means decreased energy, means criteria, 5 symptoms criteria is fulfilled, depression criteria is fulfilled. Now she has been hearing voices telling her that she is worthless. Means hearing voices, that is hallucination. Hallucination is psychotic symptom. Yes, if you forget about this, if you forget about this, I ask you, yes, up to this, what is the diagnosis? In this question, up to this, what is the diagnosis? Diagnosis is mood disorder, means depression with psychotic feature. Definitely, a patient is having five-month history of all criteria of depression fulfilled and having psychotic symptom. So depression with psychotic feature. The answer would be this. Yes, in the same question, yes, in the same question, 5-month history of these symptoms, and patient also tells that she had episode of schizophrenia 10 month back. What I said? Yes, this patient, yes, I have taken only this part till now. Yes, these are clinical pattern, how these questions are being asked and can be asked. Okay, these symptoms are there. You made the diagnosis of depression with psychotic symptom and you took history and you found that patient was having schizophrenic episode 10 month back, and for that she took treatment and now she is having only auditory hallucination. Now the diagnosis will change from depression with psychotic feature to post schizophrenic depression. So in post schizophrenic depression, criteria is there. Yes, in post schizophrenic depression, the patient should have depressive symptoms fulfilling the criteria, first thing. Second, past episode of schizophrenia within 1 year. Past episode of schizophrenia within 1 year. So 1 year, 10 month back, patient is having schizophrenic episode. There must be at this time psychotic symptom should be there. So this is 3 points to make the diagnosis of post schizophrenic depression. So in this question the answer would be post schizophrenic depression. So I have not touched this history till now. Yes, question number 3 I have divided like this. Now I join this question. I complete the question. She first heard these voices 7 months ago. When they started to make fun of her, she does not drink alcohol or use illicit drugs. Physical neurological examination show no abnormalities. Okay. On mental status examination, her speech is slow and monotonous. She abruptly stops talking in the middle of sentence. Yes, and does not finish them. That is thought block. That is thought block. So thought block is there, hallucination is there for how much duration? 7 months. Yes, means schizophrenic symptoms are present for 7 months. Schizophrenic symptoms for 7 months. Yes, depressive symptoms are present for 5 months. Yes, now the diagnosis would be, yes, if symptoms of depression and schizophrenia are present during most of the time of illness, then diagnosis may be schizoaffective disorder. Means symptoms of schizophrenia is there, symptoms of affective disorder is there, but there should be a period of at least 2 weeks. This period is 2 months in fact, but the criteria says that there should be a period of at least 2 weeks. Yes, in which only and only psychotic symptoms are there. So in this question, yes, if you take the complete question, yes, the diagnosis is schizoaffective disorder. Yes, the complete question. Patient was having depressive symptoms. Patient was having schizophrenic symptoms. Both symptoms were present during most of the duration. Means that is around 5 months. Both symptoms were present, but initial 2 months only psychotic symptoms are there. So in this question, the criteria of schizoaffective disorder are fulfilled. So diagnosis would be schizoaffective. So I told you how question can be changed. One question, yes, can be framed or different answer can be framed. So question number 3 is complete. Now question number 4. Again, I have taken two questions. In question number 4, a 30-year-old man started a new job as a product manager. 8 months ago, come to physician because of 7-month history. Duration is 7 month. Yes. Started a new job. Sometimes started a new job is considered a stressor. Okay. The patient has history of sleep disturbance. Sleep disturbance is there. Restlessness is there. Yes. Difficulty in falling asleep. Yes. He is worrying about his family, next day meeting, finances, means worry every time. He is worried about each and every aspect of life. Yes, he can no longer concentrate. Concentration is low. Feels tense. Tension is there. Avoid socializing. He appears anxious most of time. This is typical picture of generalized anxiety disorder. To remember, there is a mnemonic watchers. There is a mnemonic watchers, WATCHERS, watchers. W for worry, excessive, excessive worry, anxiety, T for tension, C for concentration, H for hyperarousal, E for energy, R for restlessness, S for sleep disturbance. So we found that out of these, initial two symptoms must be there to make the diagnosis of GAD. Yes, excessive worry should be there, anxiety all time should be there, and out of these 6, 3 symptoms should be there, 2 plus 3 to make the diagnosis of GAD. So in this question, yes, there are 2 major criteria, that is worry, excessive worry. Yes, excessive worry is there, and anxious most of time is there. Excessive worry about family, next day meeting is there. So initial 2 points are there, and 3 out of 6 is there. Restlessness is there, sleep disturbance is there, concentration is there. So fulfill the criteria of generalized anxiety disorder. Previously we were not concerned about the numbers of to make the diagnosis of generalized anxiety disorder, but now we are much more concerned about the numbers, because in the same question, yes, if diagnostic criteria of anxiety, generalized anxiety disorder is not fulfilled, the diagnosis would become adjustment disorder with anxious mood. So many doubts of students that how we can differentiate between adjustment disorder with anxious mood and generalized anxiety disorder. Yes, suppose there is a stressor, new job, breakup, financial loss. After that, patient may present with anxiety symptoms just like generalized anxiety disorder, but he would not fulfill the criteria of generalized anxiety disorder. If criteria of generalized anxiety disorder are fulfilled, the diagnosis would be generalized anxiety disorder, not adjustment disorder. Got the point? In this question, yes, physician recommends psychotherapy and medication. Yes, the treatment of choice of generalized anxiety disorder is cognitive behavior therapy plus SSRI. Cognitive behavior therapy plus SSRI. That's why the patient is given psychotherapy in the form of cognitive therapy and SSRI. So in this first question is solved, the answer is generalized anxiety disorder. Yes, what about the other option? Let me tell you after some time. He has struggled intermittently. I extend the discussion. Yes, with erectile dysfunction. You all know that SSRI is associated with sexual dysfunction. So if a patient having sexual dysfunction comes to you, you will never prescribe SSRI, then you will give buspirone. So in this question, they gave erectile dysfunction in the past, and what would be the most appropriate drug in this patient? Suppose they don't give history of erectile dysfunction, the answer would be escitalopram, but they gave history of erectile dysfunction, you will mark answer buspirone. What about panic disorder? In panic disorder, you will find episodic anxiety, sudden, severe, spontaneous anxiety, that is panic disorder. Social anxiety disorder, patient is having anxiety in a particular social situation. Suppose a person whenever goes to a restaurant, he is unable to eat a particular food or some food at restaurant, yes, and the same food he eats at home very comfortably, means it's the situation. In a social situation, patient is having anxiety to perform an action, that is social anxiety disorder or social phobia. It is called social phobia. And in phobias, the treatment of choice is behavior therapy plus SSRI. You all know, all anxiety disorder, the treatment of choice is cognitive behavior therapy plus SSRI. But in phobias, the treatment of choice is behavior therapy plus SSRI. So question number 5, before going to question, you must have an idea about somatization disorder, hypochondriasis. Yes, in somatization disorder, patient would come to doctor with multiple symptoms, means multiple systems are involved, just like neurological symptoms, pseudo neurological sign. Patient would say that I am having tingling sensation, I am having numbness in my limbs. Yes, that is nervous system involved. GI system, that I am having constipation, I am having diarrhea, vomiting, these symptoms are there, pain abdomen is there, pain symptoms, pain at multiple site, yes, wrist, I have pain at my wrist joint, I have pain in my back, I have headache. Genitourinary symptoms may be involved, that is burning during maturation, premature ejaculation, means patient will present with multiple systems involvement or sometimes one or more than one symptoms. Doctor will not find any sign, means symptoms are there, doctor find no sign. Investigation, definitely we will advise few investigation, all investigation are normal, but in this patient is concerned with the symptoms. Patient want to know that what is the reason of my symptoms, that is somatization disorder. Patient would go to another doctor. Patient would go to another doctor. Doctor Sahab, you can't handle my situation. So multiple doctors, multiple investigation, multiple symptoms. Yes, and duration is 6 months. For 6 months, then you will make the diagnosis of somatization disorder. In yes, somatization is according to ICD-10. Now you must remember ICD-11. Bodily distress disorder, bodily distress disorder. So they may give same question and they may give different option, that bodily distress disorder or somatic symptom disorder according to DSM-5. So in somatization disorder or somatic symptom disorder, the patient is concerned with symptoms, multiple symptoms, and doctor find no sign, multiple doctor visit, multiple investigations are there. In hypochondriasis, patient is preoccupied with the thought of deadly disease, means again patient will present with symptom. In hypochondriasis, patient present with symptom, doctor find no sign, multiple investigations are there, but in hypochondriasis patient is preoccupied with the diagnosis. Patient would come to you, Doctor Saab, I might be having brain tumor, I might be having some cancer, I might be having HIV, I might be having myocardial infarction, means patient will present to you with a particular diagnosis because he has thanatophobia, means fear of death. So how to differentiate between somatization disorder and hypochondriasis? Very simple. In hypochondriasis, lethal disease, patient is preoccupied with lethal disease, while in somatization disorder patient is concerned with symptoms. Okay, otherwise multiple investigation, multiple doctor visit would be same. Now we see the questions. Lalu Prasad, 45-year-old male, presented with OPD complaining of continuous non-progressive headache from last 7 months. criteria of duration of 6 months is fulfilled. Yes. He believes that he has brain tumor. Yes. Means lethal disease. Means patient is preoccupied with lethal disease, brain tumor. For that he is consulting many neurologists, multiple doctors. Neurological examination was found to be normal. Doctor find no sign. Yes. Past even all investigation has been normal. Leave it. Yes. All investigations are normal. Patient request again and again investigation to confirm the diagnosis. Means patient is preoccupied with the lethal disease. The diagnosis is hypochondriasis. In DSM-5, the name is illness anxiety disorder. So in long question, many times you will find the answer hypochondriasis, many times you will find the answer illness anxiety disorder. So in this question, answer is B. But what about somatoform pain disorder? Yes, we are confused because there are so many different classifications, but we want to solve our questions. So let me simplify. In somatoform pain disorder, everything would be just like somatization disorder, but the patient is having only pain at one or more than one site. One or more than one site. Yeah, this is again I am telling you the old classification, but questions are asked. Yes. So in the same question, as I told you that how question remains same and single line, one or two line are changed and answer is changed. In the same question, yes, if I remove these red lines, yes, the patient 45 male present with open complaining of non-progressive headache for last 7 months. Means he is having headache, but he is not preoccupied with the brain tumor. I have removed this line. For that he is consulting many neurologists. All neurological examinations are found to be normal in the past. Even all investigation are normal. Yes. In the same question, if we remove the preoccupation of the brain tumor, then the diagnosis would become somatoform pain disorder. Got the point? Pain at one site or multiple site? Yes, multiple. Yes, all investigation are normal. No sign is there. Yes, diagnosis is somatoform pain disorder. Organic brain disorder. Yes, we have ruled out organicity by multiple investigation and neurological examination can't be the answer. Question number 6. Yes, personality disorder is a very confusing. Many times you will be confused between schizoid personality and avoidant personality disorder. You will find that schizoid personality and avoidant personality, both they prefer solitary activity. Prefer solitary activity. Less friends or no friends. They have less friends or no friends. Yes, avoid social interaction. They avoid social interaction. So when you will find question on personality disorder, yes, and you want to differentiate between schizoid and avoidant personality disorder, you will find the statement, yes, the picture, clinical picture more or less same. And how you will differentiate? Yes, schizoid personality disorder, they enjoy being alone. They enjoy, let me write like this, they enjoy being alone. Means this is egosyntonic. Egosyntonic. They want to remain alone. They are happy to remain alone. While in avoidant personality disorder, yes, they remain alone, but they want to mix up. They want to interact socially, but they avoid because of the fear of being criticized. They avoid for the fear of being criticized. Don't get confused with the symptoms. Yes, that these symptoms are given. Yes, we usually mug up the symptoms of schizoid personality disorder and avoidant personality disorder. This is not the differentiating point. The differentiating point is egosyntonic and egodystonic. So avoidant personality disorder, in few literature we say avoidant personality disorder are egodystonic. These are egodystonic. Means not agreeable to self. So in this question, yes, a 17-year-old girl Yes, the age is adolescent. You all know question is asked that personality is formed during adolescence. Brought to physician by her father because of concern that her behavior during past 2 years. Yes, around 15-17 years. You know, adolescence, personality is formed during adolescence. She does not have friend, less friend, spend most of time reading by herself, means they prefer solitary activity. Her father says that she come up with excuse to avoid family dinner and other social event. Don't be confused with avoid. Yes, this is not the point by which we can find the answer. Yes, they prefer solitary activity, they avoid social situation. She states that she likes reading and feel more comfortable on her own. So this is the point. She states that she like reading and feel more comfortable on her own. This is the point by which you will say the answer is schizoid personality disorder. So in this question the answer is schizoid personality disorder. In the same question, if I replace this line with this, yes, her father says that she come up with excuse to avoid family dinner and other social event. When she was questioned, she breaks through in tears and says that reality is no one wants to be friends with ugly, stupid like me. Yes, now the diagnosis would become avoidant personality disorder. Means it is the explanation. Many times I have given this point in my class also, that it is the explanation of the patient which will determine the answer of phenomena. Okay, so if patient says that I am happy to be remain alone, then it is egosyntonic, that is schizoid personality. If patient says that I want to mix up but I am afraid of being criticized, the answer would be avoidant personality disorder, that is ego dystonic. In fact, most of the personality disorder are egosyntonic, but at few places avoidant personality disorder is considered as ego dystonic. Remember this point. Okay, now if we want to exclude schizotypal personality disorder, yes, if we want to exclude schizotypal and antisocial, you can easily schizotypal magical thinking is there, odd and eccentric would be there, sometimes hallucinations are there, so easily rule out. Antisocial personality disorder, you can easily rule out unlawful behavior is there, don't respect the right of others. So answer in this A. Okay. Question number 7. Yes, autistic simple clinical picture is of autism. Let me tell you, in autism there are three criterias. Previously there were three criteria, now there are two. Yes, now we say autism spectrum disorder according to ICD-11 and DSM-5. So what is autism spectrum disorder? In this there is decreased social communication, the patient don't interact, no eye to eye movement, no social smile, no attraction towards mother, no attachment towards mother, no anxiety towards stranger. That is means social interaction is poor, social development is poor. First thing, there is stereotypic behavior. Stereotypic behavior may be reflected in motors. In question, the patient is having stereotypic movement, wringing of hand, that is stereotypic, means spontaneous, odd, repetitive. Yes, spontaneous, odd, repetitive, purposeless movement. Yes, banging head, putting hand in mouth, shaking hands. So these points you will find in the question. Means they will say that the patient is having stereotypic motor movement. Stereotypic behavior means patient prefer to play with a particular toy. Yes, patient go to school through a particular way, means that is stereotypic behavior. So stereotypic means repetitive or same behavior, and social communication, social development is not there. So these are two criteria to make the diagnosis of autism spectrum disorder. Previously there was third criteria of language. Means patient will not develop language, la, da, ma, pa, monosyllable 6 month, 9 month bisyllable. Yes, patient will not develop these monosyllable and bisyllable, then word, then sentence, language development. But recently, this language criteria in ICD-11 and DSM-5 have been removed. Now there are only two criteria in autism spectrum disorder. Now we see the question. A 5-year-old girl, yes, is brought to physician because her mother has received multiple complaints from her teachers at school. It is not so specific. She does not complete her assignment, does not listen to her teacher instructions. She don't talk to her parents or peer. Means language development, it gives hint about language development. Her mother says she ignores everything I say to her. She prefers playing alone, and her mother reports that she likes playing with 5 red toy cars. Means that is stereotypic behavior, repeatedly arranging them in a straight line. Okay, so this is stereotypic behavior. She avoid eye to eye contact with mother and the physician. Means social development is poor. Physical and neurological examination show no abnormality. Which of the following is most likely diagnosis? So in this question, I have deliberately put all these four. Yes, but simply answer is autism spectrum disorder. If this type of question is asked, no need to think. If autism spectrum disorder is given in the option, the answer would be autism spectrum disorder. But there are few questions, yes, according to ICD-10, and in which they want to differentiate. You must differentiate between autism, Asperger syndrome, Rett and Haller. How to differentiate autism? All three criterias, means stereotypic behavior, social development and language development, all are affected. All three criteria. In Asperger syndrome, autism minus language, means Asperger syndrome language is normal, but other two criterias are there. Rett syndrome, yes, it is in females, more common in females, much more common in females than male. Previously we used to say they are exclusively found in female, but few cases of Rett syndrome also seen in males also. In this you will find microcephaly. You will find the question that patient, yes, patient is having microcephaly, normal development till 5 months, normal development till 5 months, after then regression. So if you find in a question that there is a female, yes, there is symptoms of autism are there, yes, I have told you three criteria are there, yes, and the patient was normal development till 5 months, after then regression is started, there is breath holding spells, yes, many times in question you will find that Rett syndromes are having breath holding spells, yes, and these are more common in females. The answer would be Rett syndrome. In Haller syndrome, you will find the whole criteria of autism, but you will find point how to find the answer, how to catch the answer, that till normal development till 2 year, after that there is regression. Yes, in Rett syndrome normal development till 5 months. In Haller syndrome, the normal development is till 2 years. Yes, question number 8. Before going to question number 8, simple. Whenever you find a question on patient, yes, patient is dressed with opposite sex, means cross dressing, cross dressing. Whenever you find a question and patient is wearing clothes of opposite sex, you will see the catching point. Patient want to change sex, want to change sex. If patient is wearing clothes of opposite sex and patient want to change sex, is not comfortable in with his sex, yes, he says that I am a man trapped in female body, I am a female trapped in male body and I want to change them, then the answer would be transsexualism. Transsexualism. Yes, if patient says that I am enjoying a temporary feeling, means I don't want to change my sex, I am feeling some more confident, okay, I am having temporary feeling to belong of opposite sex, then the answer would be dual role transvestism. Transvestism. If patient says that after wearing clothes of opposite sex, yes, I feel sexual arousal and gratification, sexual arousal and gratification, then the answer would become fetishistic Transvestism. Yes, if sexual arousal and gratification after wearing clothes, fetishistic transvestism. So now we see the question. A 20-year-old Nilu enjoy wearing male clothes. Wearing male clothes gives her feeling of more confidence. Yes, more confidence means no sexual arousal. Yes, no desire to change. Yes, after that episode she is absolutely normal girl, means no desire to change the sex. The answer would be dual role transvestism. But in the same question, if they add one more sentence that she want to change her sex, yes, want to change her sex, the answer would become, yes, in the same question, if they say that she wants to change her sex, then the answer would be transsexualism, change sex. If same question, patient says that yes, after wearing male cloth I am getting sexual arousal, I am getting sexual arousal, the answer would become fetishistic transvestism. So this is question number 8. Question number 9, lithium has been a very important topic for PG entrance exam. So let's see. A patient was on lithium therapy for bipolar disorder for 6 months. Yes, and we know that in lithium is having very low therapeutic index, and lithium is excreted by kidney. She kept fast for few days due to religious reason. Yes, this is precipitating factor. This is important. Presented with coarse tremor, abdominal pain, vomiting, dizziness, confusion. Yes, all these are features of lithium toxicity. Lithium toxicity. Yes, you must remember that normal side effect of lithium and lithium toxicity. Normal side effects are, yes, fine tremors means, yes, patient is, no, you can't see these tremors, but if you put a paper on hand, then you can see that fine tremors. Yes, if a patient is on lithium, comes to you after 6 months, he or she is having fine tremors and she is having nausea, no need to worry. Fine tremors and nausea are normal side effect, and you will treat the patient for fine tremor by beta blocker, propranolol. Question. But the same patient taking lithium for 6 months now comes with coarse tremors. Coarse tremors are there. Confusion is there. You will check the reflex. Hyperreflexia would be there. Vomiting, abdominal pain would be there. These are sign of lithium toxicity. Yes, you will immediately send the lithium level. Yes, serum lithium level, and will decide the treatment. Yes, the definitive treatment is dialysis. Dialysis. Okay, question is asked, if yes, lithium toxicity, we can do dialysis. Few questions of lithium, yes, recently asked in INI's is sorry AIMS and different Apex Institute. So let me tell you few points about lithium. Lithium just behave in our body, just yes, behaves in our body just like sodium. Lithium behave just like sodium. It is having very low therapeutic index. Low therapeutic index means 1 to 1.5 millimole per liter. Yes, this is effective concentration. Yes, this is different in different test books, and in same test book also. Yes, 0.8 to 1.2, yes, sometimes written. So 1 to 1.5 it is written in Kaplan itself, and if more than 1.5 millimole per liter, then it is toxicity. So it is very no narrow therapeutic index. And you know, lithium act just like sodium in our body, lithium and sodium. So lithium is excreted by kidney just like sodium. So whenever you start lithium, always do kidney function test, serum creatinine. Question is asked. Lithium behaves just like sodium, so it will behave in thyroid gland. Yes, iodine trapping, sodium is useful, lithium will replace it, so may produce hypothyroidism. hypothyroidism. So before prescribing lithium, we do thyroid function test question. Yes, in heart it will replace sodium, so we always advise ECG before starting lithium. Now the half life, yes, half life of lithium is 1.3 days. In pharma you must have read that a drug achieve steady state concentration after 4 to 5 half life. 4 to 5 half life means when you start lithium, lithium will achieve steady state plasma concentration. Yes, plasma steady state concentration after 4 to 5 half life means 5 to 7 days. 5 to 7 days. So question is asked that you advise serum lithium after how many days of starting lithium? Yes, we advise after 5 days. We advise serum lithium level after 5 days. And when you will take the sample, yes, blood sample for lithium should be taken 12 hours, 12 hours after last dose. And as you know that it is excreted by kidney means, and it is having very low therapeutic index. Many times whenever there is blood volume loss or level plasma level is changed, just like after diarrhea, after vomiting, in postpartum period, yes, many times what will happen, the blood volume will decrease and that may precipitate lithium toxicity. So whenever you find questions, you find, yes, whenever you find question on lithium, clinical question on lithium, many times you will find the history that fast, diarrhea, vomiting or some hemodynamic change would be there. Yes, some symptoms suggestive of hemodynamic change. There is a very important controversial question that where we should use lithium and where we should use valproate. Yes, lithium indication over valproate. Yes, if you find family history of mania, you will prefer lithium. Yes, I have taken this triangle of family planning. If you remember this triangle, you will remember. Yes, family history, all these, if the three persons are there, the family would be happy. If euphoric mania is there, yes, mania may be of two type, euphoric, irritable. Irritable mania, we prefer valproate. Euphoric mania, we prefer lithium. Family history of mania, we prefer lithium. 3 or less than 3 episode. How many persons are there? 3. 3 or 3 less than 3 episode, we prefer lithium. Manic depressive illness, what does it mean? Suppose a person is having 3 episodes in BPAD. First is mania, second is mania, third is depression. Means more manic episode, less depressive episode. This is called manic depressive illness, means more mania episodes, then you will prefer lithium. Absence of any substance use means if substance use history in family is not there, you will prefer lithium. Means history of substance use, prefer lithium, sorry, valproate. Remember one point, many times you will find clinical questions in which they will say all the indication, they will give you question in such a way that indication of valproate you will think of valproate, but they will give a young female of 26, newly married or simply married, childbearing age, never ever prescribe valproate. So you will rule out valproate if you find a young female, childbearing age. Remember this point. Now the last question. A 17-year-old woman, yes, first the age, the adolescence, female, yes, we are taking eating disorder, and you all know eating disorders are more common in female than male, and the age is adolescent. First year in college comes to see for general examination. She is not concerned with any eating disorder. She came for general examination. She is calm and thin woman dressed in a very baggy jogging suit. You comment on her thinness, means she appeared thin to you. Means you are clinician, you found her to be thin. She denies problem with eating too much or too little. Means she denies many times. Yes, let me describe initially, this is a case of anorexia nervosa, and let me describe in such a way. Anorexia nervosa is common in adolescent girls. Yes, first thing, they are secretive, they don't disclose their thought that they are having eating problem, they are having these problem of body image. Let me describe. Yes, so she denies problem with eating too much or too little, and she says just diet and exercise help her to control her weight. Despite your concern about her thinness, she tells you she would like to lose a few more pounds, means she want to lose more weight in spite of having a very thin build, means she might be having body image disturbance. In body image disturbance, what is body image disturbance? Patient think himself or herself, yes, to be fat. Yes, in this case the girl thinks that she is fat, she require more weight to lose. Clear? She tells that she has not had a regular menstrual period for over a year, means amenorrhea, or yeah, that is irregular menstrual cycle. And amenorrhea is common, very common in anorexia nervosa, 70% case. Important point, this can be asked previously. To make the diagnosis of anorexia nervosa, we used to say that amenorrhea must be present in female, but this criteria has been removed from DSM-5, means this is not compulsion, but even now this is present. The patient has BMI 16.4 kilogram per meter square. Yes, according to ICD 10. If you want to make the diagnosis of anorexia nervosa, the BMI should be less than 17.5. But according to ICD 11, the BMI should be less than 18.5. So this is change can be asked. Upon evaluation, the patient describe a repeated pattern of binging on large meal. Yes, what is binging? Binging means ingestion of large amount of food in a short time. Large amount of food in a short time. That is binging. Followed by forced vomiting. Forced vomiting is called purging. Yes, that is purging. She also use laxative every night before she goes to bed to prevent constipation, means she is adopting different way to compensate large amount of food intake if she do. The patient reports that she has been running 3 miles every day, but in the last, means one more compensatory mechanism is by exercising. But in last few weeks she has become too tired to run. The most accurate diagnosis for the patient is. So in this question you will find that there is binge eating and purging. Yes, there is episodes of binge eating and purging, and there are criteria of anorexia nervosa. And binge eating and purging is common in bulimia nervosa. Yes, in bulimia nervosa, what happens? The patient ingest large amount of food in a short time, and after that do purging in the form of vomiting. Again and again she would vomit. Yes, when vomit again and again, what happens? That there is scar mark, callus formation on the knuckle, that is called Russell sign. Okay, parotid enlargement. So these symptoms are typically present in bulimia nervosa, but these episodes of binge eating and purging may be present in anorexia nervosa. So anorexia nervosa may be of two type, that is restrictive type and binge eating and purging type. So how to differentiate between anorexia nervosa, binge eating, purging type and bulimia nervosa? In this question, yes, we are confused with anorexia nervosa, binge eating and purging type, and bulimia nervosa. How to differentiate? And the catching point is BMI. If BMI, yes, if BMI is less than 17.5, yes, the diagnosis would be anorexia nervosa, binge eating and purging type. So in this answer is C, anorexia nervosa, binge eating and purging type. Simple question. Yes, many times these long questions are there, and whenever you find that there is binge eating, purging and you find BMI, Yes, no need to read all these details. Answer would be anorexia nervosa. The catching point in eating disorder many times is BMI. Less than 17.5, anorexia nervosa. More than 17.5, and now ICD-11, more than 18.5 means in bulimia nervosa, the weight is normal. So these are the common topics on which question can be asked, and these are high yielding topics.